Good morning, everyone. My name is Liz Dorman. I'm a child psychiatrist with the Department of Mental Health's Juvenile Justice Mental Health Program and a recent graduate of UCLA's Child Psychiatry Fellowship. And I am thrilled to join you all today to introduce my esteemed colleague, Dr. Laura Halpin. Those who know Laura know that her brilliance is matched only by her humility and unwavering commitment to serving the underserved, promoting health equity, and navigating complex systems of care on behalf of patients and their families. This morning, Laura will walk us through the experiences of two families she led through the maze of school detainment, justice involvement, and inpatient mental health treatment. These cases illustrate multiple systemic challenges that families in our community face. And most of these families do not have a guide like Laura. By illuminating gray areas and cutting through red tape, Laura facilitated outcomes that would not have been possible without her advocacy. Through these cases, Laura will discuss the implications of these contact points with justice-involved youth, the role played by the mental health care system, and hopeful changes that are underway in the juvenile justice system in Los Angeles County. Laura is an Ohio native and received her undergraduate degrees in chemistry and biology, summa cum laude, from the University of Toledo. She continued at Toledo for her MD and PhD, where she was named to the Gold Humanism and Alpha Omega Alpha Societies, and conducted research into the neurotoxicity of methamphetamine. She continued her research as a postdoctoral fellow at the Translational Methamphetamine AIDS Research Center at UCSD, prior to starting general psychiatry residency at UCLA, where she concentrated in community psychiatry. We were then lucky enough to have her stay for her child psychiatry fellowship. In recent years, Laura has been the recipient of the APA Leadership Fellowship and has published on community interventions to promote health equity. While serving as the Child and Adolescent Inpatient Psychiatry Chief this year, Laura also saw to fruition the development of a formal UCLA policy to guide emergency psychiatric evaluations of adults in the custody of law enforcement, a vital contribution. She is also at work drafting formal recommendations for inpatient child and adolescent psychiatrists in supporting justice-involved youth, some of which she will share with us today. And with that, please join me in a virtual round of applause to welcome Dr. Laura Halpin.
Oh, thank you, Liz. Okay, I'll go ahead and share my screen. All right, yeah, thank you so much for the introduction, Liz. That was very, very, very kind. I appreciate you all taking the time to join. If you have any questions throughout the presentation, feel free to put those in the Q&A box instead of using the chat function, since we'll be able to maybe answer some of them as we go. And then also, if not, hopefully we'll have plenty of time at the end for a little bit of discussion and answering some questions. And then I have no disclosures. So thanks for joining. The title of my talk today is going to be Justice Involved Youth in the Emergency Department and the Inpatient Unit. And as Liz noted, it's going to include both a case discussion and then a more in-depth discussion about kind of the state of youth diversion in LA County. And so I'll start off giving you guys a little bit of background about the justice system and justice-involved youth, and then talk about two different cases, one in the emergency room and then one on the inpatient unit. We'll discuss the cases a little bit and then move into kind of a broader discussion about diversion in LA County. And then we'll have both Dr. Dorman as well as Dr. Thompson leading kind of more discussion and more Q&A about the state of things in LA County. And I guess I just want to start off with some acknowledgements. As Liz kind of noted in the introduction, working with youth who are involved in multiple different systems is definitely a challenge and not something that can be done alone. And so I just want to first acknowledge the support of both kind of the inpatient and the emergency room teams and attendings, as well as social workers. And then because, you know, healthcare and money, all the people who help us with, you know, inpatient authorizations and sort of things, Miranda and Kelly. I also want to acknowledge Dr. Dorman and Dr. Thompson for providing me a lot of the information and the data that I'll provide later in the presentation, and then also for being willing to be here and part of the Q&A and discussion. I also want to give a shout out to Dr. Bath, Karina, and then Jessica. Karina's a first-year fellow and Jessica's a sub-I who I'm hoping we're going to be able to convince to stay here for residency. And we've worked together with some of these patients, and we're also working on developing some manuscripts related to some of this work. And then finally, I just want to thank a work group who I worked with to develop the policy that Liz talked about, and I'll talk about that on one of the slides in a little bit too. All right, so just to get into it, I want to start off just talking in general about justice-involved youth and mental illness. As many of you may be aware, over the course of recent decades, there's been a movement towards decarceration of youth. It reached its peak kind of in the mid-90s with about 2.7 million incarcerated youth in 1996, down to approximately 730,000 in 2018. And those numbers have fallen even more related to legislation and programming, and even COVID has kind of facilitated further decarceration. And I think it's important to note that even though the overall number of youth within the justice system is going down, youth with mental illness continue to be overrepresented. So for some reason, all of the things that we're doing to try to move towards decarceration aren't necessarily having the same amount of benefit that for youth with mental illness. And you can see here, this is a table, the paper's a little old, but in general, as many as 2/3 of justice-involved youth would meet criteria for a DSM-5 disorder that could contribute to impulsive or aggressive behaviors, things that likely, if treated, would have reduced the likelihood of them ending up in the system. And so not only, unfortunately, are the populations that continue to be incarcerated kind of enriched or overrepresented with those with mental illness, there's also a significant overrepresentation of Black and Latinx youth, demonstrating that there's a significant role of structural racism within the justice system. So although arrest and incarceration numbers continue to decrease, Black and Latinx youth continue to be more overrepresented. And especially within LA, I think an even more concerning statistic is not only are there more arrests, but then at every level, as you get deeper and deeper into the system, that overrepresentation continues to increase, which again is just indicative of the structural racism within the system. And so you can see here, this is from the Youth Justice Work Group, which published this really great report in October of this past year for the Board of Supervisors. And so a lot of the really impressive graphics that you guys will see come from this report. So I definitely encourage you guys to take a look at that. But you can see for every one white youth, the number of Black and Latinx youth are just really, really over. There's too many. Okay. And so when it comes to interventions and trying to think about what we can do about this. Essentially what's happening here is that the justice system is serving as a safety net for youth who aren't able to get mental health and other services and supports within the community. And I think one argument that can be made here is it's of course important to strengthen mental health services within the system itself. But the challenge of this, and this kind of inverted U basically describes the pathway that youth are experiencing currently, which is more or less, they're not able to get the services they need. As a result, the justice system is functioning as a safety net, leading to arrests and incarceration, youth getting access to services within the system, and then to get out of the system and back into the community, they have to navigate a really complex set of systems, set of rules. It takes time. And of course, is not without negative consequences. It's all time spent out of school, out of community, away from family. And so in addition to, I think, strengthening services within the system, it's also important for there to be considerable focus on community-based interventions to actually reduce system involvement, and then really formalize pathways to keep youth from getting stuck in this kind of revolving door area down here. I think another thing to think about is, with anyone, this is a concern, but especially with developmentally people who are in their teen years when they're really trying to develop their identity, spending a lot of that time trapped within these systems has a lot of really negative consequences. And so kind of the overall goal or the role that diversion would play is basically blocking all of that and taking people directly from that safety net to being able to access the community-based services. Okay, so to start to get into our first case, so the patient was a 15-year-old Latino male. He had a past psychiatric history of unspecified anxiety. The patient had had multiple prior emergency room visits for panic attacks, no outpatient psychiatrist. He had presented to the emergency room, which is the first place I was able to interact with him, with a school resource officer. That's essentially the name for school-based police. And so after having a panic attack at school, and so he had a panic attack at school, had multiple in the past. During this panic attack, he attempted to elope from the school, and was prevented from doing so by police. In the midst of his panic attack, he then threatened police and school officials, shoved a school administrator, and then was removed from the school in police custody. When he was en route to booking for the threats and having assaulted a school administrator, patient then had another panic attack, developed labored breathing and chest pain, and so he was brought to the emergency room for medical evaluation. After he was medically cleared, or in the midst of kind of the medical clearance process, the emergency room then consulted psychiatry. And so when I first kind of approached the scene, what I decided to take as my first step was speaking with the school resource officers or the police in the hallway away from the patient, just to try to find out what had happened. The way they described the patient is he's been on our radar for months due to truancy issues. They described the events of the day. It sounded really consistent with a panic attack, adding, he's missing so much school. We think he's manipulating the system. He's using drugs. He has pills on him. There's a lot of bad stuff going on. The police noted that their plan was to take the patient to juvenile hall after the emergency room visit. So I then evaluated the patient, first asking the police to step away. He reported he was terrified. He'd said he had a 4-month history of panic attacks with multiple ER visits throughout the county. And this was substantiated. Like I was able to see that this was the case through Care Everywhere. He'd had intermittent prescription benzodiazepine use. And again, this was verified by Cures. These were things that were prescribed in emergency room visits after he would be discharged for having a panic attack. And then was concerned that maybe he was having withdrawals. He was also experiencing a lot of environmental stressors that he told me about in the emergency room, a knee injury that made it so he wasn't able to play football, and then conflict with his girlfriend. So I was definitely very concerned for him. And so we developed a plan, basically due to the concerns about his escalating panic attacks, increasing functional impairment, and the police involvement, and this real inability to access outpatient care. He'd really had multiple ER visits over the course of months. And each time, the plan was, okay, take these benzos when needed to prevent the panic attacks, but establish care with an outpatient psychiatrist. And the family had been trying and they just really hadn't been able to. And so I then had a meeting in the emergency room with the police and the family, kind of with family consent. And really trying to make an argument for admitting this patient. And you'll note this is kind of atypical. We don't necessarily regularly or even hardly ever admit people when they're having panic attacks. But my concern was so significant because of what was happening at the school. And so after framing the presentation from the perspective of the psychiatric disease requiring admission and treatment, and the idea that what the family and what the different emergency rooms were trying to make happen in terms of outpatient care wasn't happening. Eventually, the parents, as well as the school resource officers, agreed to leave the patient in the custody of the emergency department, and eventually the inpatient psychiatry team. And so the school resource officers were willing to leave the patient there versus leaving sometimes the patient will remain in their custody and they'll want to kind of stay with the patient, but they were okay leaving him as long as we were able to move him to from a hallway room to one of the different rooms in the emergency room. And the emergency room was really willing to do that. Because we didn't have a bed yet, the patient was placed on a hold as part of the board and transfer process. And then also as part of the hold, as you guys know, there might be that box on there that the school resource officers or whoever's bringing the patient in can check to be, if they're legal people, can request to be contacted when the patient leaves the facility. So the patient was then admitted. He had disclosed that he had a significant trauma history related to his brother being shot and killed, and was meeting criteria for PTSD. The patient and family, we had multiple family meetings to talk about PTSD, to talk about panic disorders, to talk about medication. The patient was started on Prozac, and we were able to link him with both Star Clinic as well as an FSP. And then while he was in the hospital, I think he had maybe about a 4 or 5 day stay, family was also able to engage legal services. And so then on discharge, we still contacted the school resource officer because that was requested as part of the hold. However, the patient and his lawyer, his legal services, were able to go with him to be booked, and then he was able to go home after booking. There was no kind of pre-adjudication detainment or being sent to juvenile hall. So a couple things to consider with regards to this case. Anytime we're asked to evaluate a patient in the emergency room, of course, the things we're thinking about are what level of care is indicated for them. Are they meeting criteria for a hold? And I think my first note is if you're seeing a patient who's in law enforcement custody, really consider how it's affecting your evaluation. And noting that even though there may be a tendency or even a thought that, you know, oh, okay, if they're in law enforcement custody and they say they're taking the patient and the patient needs to go to jail or needs to be detained, that doesn't necessarily have to be the case, especially if the patient is needing kind of inpatient level care. When you're seeing a patient in the emergency room who's in law enforcement custody, make sure you ask the law enforcement to step away to protect the patient's confidentiality and to help the patient feel safer. Then explain your role very clearly to the patient, differentiate from law enforcement, allow them to ask any questions about your role before the interview. It may not be clear to them like who you're working with, who you're a part of. Let them know that, you know, I'm here for a medical evaluation. I'm concerned about, you know, your safety, and I really want to try to help. And I think also note that the patient's very likely to be under duress, possibly in the midst of a traumatic experience. They may not be willing to engage and or may not be forthcoming. And often when we see those behaviors, we're almost trained in a way to think that, oh, this may be consistent with malingering, or this may be consistent with someone who may not need inpatient level care. But really consider the behavior in the context of the law enforcement custody, and what that patient is experiencing right there and then in that moment is not typical for the patients we typically see in the emergency room. And then of course, as you're documenting the encounter, definitely document any information you receive using words like reports, per patient, allegedly. If you aren't sure, it's okay to just document in general terms. Keeping in mind that that your documentation could eventually be subpoenaed. And I think the other thing is sometimes to let your patient know that what they're telling you is protected by HIPAA, and that if someone wanted to get records of your conversation, that it would have to go through a formalized process. A couple other considerations anytime you're seeing someone in law enforcement custody. First of all, keeping in mind that someone who's in law enforcement custody may be likely to have other risk factors that increase their severity of illness and or treatment needs. So kind of the same population, being in law enforcement custody is consistent with a lot of things. That's also going to make it really hard to get psychiatric care, especially in kind of the current state of our system. So it could be consistent with not having access to treatment, medications, consistent supports. It could be consistent with a history of substance use disorders, housing status, school-based supports, as well as increased risk for trauma, abuse, and ACEs. And then also those who are ending up in law enforcement custody first, outside of, you know, some other way that they're accessing care and accessing our system, are more likely to be victimized by racism, structural and otherwise, which is also very pervasive in healthcare. So I often encourage people to almost think of being in law enforcement custody, like when it comes to heart disease, we think of diabetes as like a heart disease equivalent. When it comes to psychiatric evaluations in the emergency room, when someone's in law enforcement custody, I would encourage you to almost think of it as like an inpatient level equivalent. So in general, in the current treatment climate, where we don't have adequate community-based resources, and our healthcare system doesn't have an effective way to target all of these modifiable risk factors, it's prudent to likely consider more strongly the role of hospitalization and have more concern when assessing for risk of danger to self and others, as well as what people may need to meet their basic needs. And then I do also want to let you know, as I'm encouraging you to potentially intervene in the setting of, law enforcement and police, possibly recommending a disposition that's not consistent with what the police were planning on. I do want to make sure you're aware that there is UCLA policy that encourages your independent clinical evaluation of that patient, and then also gives a pathway to kind of support trying to make that disposition happen. And so I think most of you probably know, but you can locate policies and procedures through MedNet. This is the name of the policy. If you just try to remember law enforcement, if you type that into the search bar, you should be able to find it. But the couple things this policy does, first of all, is says that our evaluations can and should be done independent of law enforcement custody, and that your recommendations when it comes to psychiatric holds and hospitalizations should also be made regardless of law enforcement custody. And then the helpful thing is, in moments where there isn't necessarily agreement, we want to hospitalize a patient, but police believe the patient needs to remain in their custody and needs to, kind of be taken to Twin Towers or to juvenile hall. It gives a process by which those communications should happen. And basically, instead of the trainee and the law enforcement having a disagreement in the emergency room, the recommendation is that each go to their respective supervisors. So for the police officers, to contact their watch commander, and then for the trainee to contact the attending, to contact the emergency room, to contact the medical directors of the emergency room, and then hospital administration. And that the communication about what should happen with the patient should happen at that level. At the end of the day, we're not able to prevent police officers from taking a patient out of the emergency room, even if it is our clinical recommendation that that patient be hospitalized. But this document does also provide a mechanism by which all of that can be documented. Okay, moving on to the next case. So this one deals with a patient who was on the inpatient unit. And so this was a 17-year-old white female with a past psychiatric history of autism spectrum disorder, depression, and ADHD. She had 3 past psychiatric hospitalizations. Prior to admission, she had been arrested for threats she made at school in response to bullying. In the weeks leading up to the hospitalization that we're talking about here, she had been discharged to a residential treatment facility, however, eloped from that facility when she was dysregulated. Shortly after elopement, she was then picked up by an older male who sexually assaulted her. And when she was trying to escape the situation, she came into contact with police, who then brought her to an outside emergency department to have a sexual assault exam. While she was there, she was found to be in violation of probation related to these charges of the school threats. And then as a result of that, she was ordered to juvenile hall. While she was in juvenile hall, the patient had a suicide attempt and then was brought to another outside emergency room. While there, a judge made an order for her to be psychiatrically hospitalized. But part of the order explicitly said, no matter what, when this hospitalization is over, she needs to return to juvenile hall. On the inpatient unit, she really struggled. She had ongoing SI and was experiencing significant symptoms related to the sexual assault. We were able to restart her medications, put her on a 1-to-1, have STI testing and HIV post-exposure prophylaxis. She was diagnosed with acute stress disorder in addition to other diagnoses, and we were able to work with her on the unit. Over the course of 2 months, the suicidal ideations resolved and her medications were adjusted. In terms of kind of what was happening legally while she was on the unit, so she was placed on a hold because related to the judge's order, the patient, if she no longer met criteria for hospitalization, had to go back to the juvenile hall. So it wasn't clear, even though family was on board with the admission, it wasn't clear exactly what would happen with consent. So she was placed on the hold, and that was continued to a 14-day and a 30-day hold. When it came to her disposition, and this was kind of the big challenge because there was that order basically saying as soon as she's stable, she needs to return to juvenile hall. So the court expressed significant concerns regarding her recent elopement in the sense that the elopement from the residential facility was consistent with kind of criminal activity, and continued to recommend that the only safe place she could go, or only stable place she could go, would be juvenile hall. And we were concerned on the inpatient team that it would worsen outcomes for her psychiatric disease, as well as limit her access to treatment, school, family support, and just a safe, stable environment. So while she was inpatient, we engaged in weekly teleconferences with a public defender, probation, her school district, as well as representatives from the court. And really just tried to consistently engage in a lot of psychoeducation about how her behavior was more consistent or most consistent with her autism spectrum disorder versus a strong motive to engage in repeated criminal behavior and kind of elope from the system. We also explained this in the setting of, how important it is, what sort of environment is necessary to encourage recovery from trauma and eventually help her reach her goals. And so eventually the court was open to considering alternative dispositions. However, due to their concern, and reasonably so, about the patient's ability to kind of stay in one place and consent to voluntary treatment when she was dysregulated, we started to explore locked residential facilities. As we started to explore these facilities, it came up that in order for her to go there, she needed to be conserved. So we then applied for LPS conservatorship, which patient and family consented to. And then eventually patient was conserved. Mom was named as the conservator. She was eventually discharged to a locked residential facility for patients with autism, which had this integrated science and math focused school, as well as ongoing treatment expertise in trauma. Other things to note about her stay. So throughout the stay, I looked back a couple days ago, I think it was about a 65-day hospital stay to kind of get all of this done. So throughout this day, we had to do multiple insurance reviews, including a lot of discussions with the actual medical director of the insurer. Next, when it came to not only funding the stay, there were also a lot of complications when it came to funding the residential. So we had a lot of discussions between the school district, insurance, the public guardian's office, and probation, as these were all potential groups to fund this day. I think at the end of the day, the school district ended up funding because it was mainly a residential school. Okay, so some clinical considerations here. During the inpatient stay, for any patient kind of coming from juvenile hall, I think it's important to really consider alternate dispositions other than return to juvenile hall. Even if as those patients are coming in, it's kind of told to us as like a foregone conclusion that this is definitely where they have to go. Doing this can often require significant advocacy, both within the hospital on the team, as well as outside the hospital to the patient's team outside the hospital. Expect to hear multiple times, the court's already decided they have to go back to juvenile hall. That's the plan, that's the disposition. And I would really encourage you to kind of continue with the advocacy regardless, especially in cases where there's a psychiatric explanation for behavior that's being otherwise interpreted as illegal or delinquent. It can be really helpful for the team to understand that and to hear that this is what we think is going on, and the way we think that this could go better is through treatment. I know it can be really hard, especially as a trainee on those teams, to be the person making that advocacy, but keep in mind, as a physician, you have a lot of kind of power and privilege in those discussions. And it's worth trying to have that experience of putting yourself out there and really trying to advocate for the patient if you do really have a sense on what is best for them. Of course, also it's important to provide psychoeducation for the patient and the family with regards to kind of these same concerns. Consider the role of psychiatric holds, locked facilities, conservatorship, all of these sorts of things. Keeping in mind that sometimes it can feel or even be as though you're trading basically one method of limiting rights for another, and really trying to think what's the least restrictive environment the patient can be in and how to get there. As you'll know, our process, especially in this case, and honestly with both cases, probably feels a little complicated and convoluted. And part of that will become notable when we talk about, this is why we need a formal process, and this is why the county is moving towards a formal process for diversion. Also consider, in addition to, the acute needs, what the patient's broader needs are when it comes to psychiatric care, school support, other things you can connect them to. And then finally, one of the last points is be sure to take some time to educate the patient and family about the system. Be open to processing failures of the healthcare and the justice system with the patient and family. I think this can be really important for kind of building trust and working together, and also talking about, the very real things that are happening in these systems to these patients. Okay. So overall, when it comes to kind of big picture in these cases, and we can talk about this more once I wrap up here in a couple minutes, but a key benefit of kind of the interventions we were able to provide here is that we were able to diagnose and treat these patients and then link them to community resources, including the wraparound services, the residential school, et cetera, that were part of the reasons these patients were kind of falling through the cracks and continuing to have involvement with the legal system. Another big benefit is that we were able to kind of slow down this automatic process of like the police are the first people to respond, and that's like a hammer and nail thing. They then use the tools they have and they take the patient to juvenile hall because that's the tool they have. And so we were able to slow things down. Family was able to engage legal services, and then we were also able to really focus on a therapeutic disposition. We were able to prevent at the time kind of a pre-adjudication stay at juvenile hall for both patients. Regardless, both patients still had charges. The first patient left the hospital with the SROs, went to be booked. The second patient ended up getting conserved, was placed in a locked facility, still had charges and ongoing court involvement after discharge. So I think these points, there's definitely some benefits and definitely some hopefully helpful things we're able to do for the patients and families. However, also noting the complicated system is still has to be worked out. And so that brings to the next part, which is just introducing the idea of kind of structural and system level change to make it so, if you remember that inverted U, really trying to take people from the safety net directly to the community-based resources versus getting stuck in kind of that revolving door. And so this is another figure from the Youth Justice Work Group, basically just looking at all the different pieces and parts in the system. Both within the, anywhere from the community members to judges having to make limited decisions, to detention staff and probation officers having limited options. And then everything else, housing discrimination, racial wealth gaps, criminalization of immigrants, over-policing of BIPOC communities. All of these things are contributing to what's happening. And it can be a challenge to envision what change would look like because so many of these things have to change. But just keeping in mind that there's a way. And instead of, there's not likely one solution, but it's kind of targeting each one of these pieces. And to talk broadly about how this happens, kind of the most widely accepted model of diversion is this something called the sequential intercept model. And so if you can envision in that inverted U curve, this being what's in that gray box and kind of broadly how diversion works. And I won't go over all the specifics here, but just so this is something you guys are aware of. It basically looks at every step of what happens with a patient from when crisis services are engaged all the way up through reentry, and looks at how at each step of this way, there's things that we can be doing to help get the patients out of the system. Okay, so now to move in to talk about kind of this on the level of LA County. Basically within the last couple decades, all of the country, all of California and all of LA County have been moving towards decarceration of youth. And some important things to highlight here, both at the county and the state level, there have been measures in recent years. Kind of starting back in, and one thing that's a little confusing about this is the words don't follow up with it, like the word to the letter is where. So starting in around 2016, the Board of Supervisors started to pass a lot of motions to increase the oversight and governance associated with probation. And around that same time, the board also developed basically a roadmap for advancing and having a formal process for youth diversion. And as noted, considering how complex these systems are, how many of the systems are interacting, and how complex it is for any individual, let alone, a family, et cetera, to navigate the system, having formal pathways for diversion is really, really important. And so this established the Division of Youth Diversion and Development. And then, so this was established kind of between 2016 and 2017. It was fully funded a little bit later in 2018. And then on the next slide, I'll show some data actually from how things have been going with the youth diversion and development. Since then, even in recent years, things have begun to progress even further. The board also passed a motion to establish this Youth Justice Work Group, whose report just came out in October of 2020. Again, that's where most of these figures are coming from. And then they've established basically a 5-year plan to really ramp up diversion within the county. Also worth noting are some of the state-based initiatives that have made a difference here. So ending the prosecution of children under the age of 12, ending the transfer of 14 and 15-year-olds to adult court, and then most recently, just in November, the closure of the Department of Juvenile Justice. And then also keeping in mind all the while on the adult side, you guys may remember hearing a couple years back about how the board was initially planning to build the $2 billion mental health jail. And then that was defeated and instead started to pursue the alternatives to incarceration movement. Okay, and so these are some of the initial data I just wanted to share from kind of the initial, kind of the first go at diversion within LA County. And so this is the office, and they're all like the same 10 words that name all of these things, and all the initials are really similar. But so this is the Office of Youth Development and Diversion. This is the first iteration kind of formal diversion in LA County. A really good thing about it is that it's not housed under probation. It's housed under DHS and specifically under ODR, the Office of Diversion and Reentry. It was established in 2017, funded in 2018, and they first started receiving referrals in April of 2019. Since then, they've received a lot of referrals, 520. A really cool thing here is that 87% is pre-booking. So this is people are going here before even getting in the system, which is really great. And then some are post-booking, and then some are more informal. And so in terms of those 520 referrals, that's what the like 100% is for all of these remaining graphs. So in terms of completion status, you'll see between these two, so between active or formally completed or substantially completed, about 75%. So a good portion of the referrals that are being sent to this office are being accepted. People are enrolling, and then they're completing most of what they're trying to complete. So whatever's happening in the program seems to be working well. I think another really important figure to note is referrals by race and ethnic identity. As we noted, is that even though youth populations who are incarcerated continue to go down, those populations continue to be kind of over-enriched in terms of BIPOC youth, and then also those with mental illness. And so when we look at referrals to the diversion program, there does seem to be a significant component of Latinx as well as Black youth. And then I think the last thing to look at here is just the types of charges that are being referred. The goal of this program is for there to be a lot of mainly felony charges. And that's important because, it's not just diverting, youth for, oops, hopefully you guys can still see my screen there. It's not just diverting youth for, daytime curfew or kind of truancy. It is for, more involved charges, things like assault and battery, theft, things that do kind of fit into those felony categories. Okay, so that was the first iteration kind of diversion within LA County. If you remember, the next step was more recently, about a year ago, the Youth Justice Work Group was formed, and they just provided their formal recommendations in October of this past year. And this is really kind of diversion taking off within LA County. And so it includes a 5-year plan, basically for conversion and expansion of YDD, so that first iteration, and to create a new Department of Youth Development, so YDD to DYD. And the goal is really to start having these community-based services that respond to the needs of youth in the community, kind of instead of police, so getting kind of out ahead of that safety net and intervening upstream. And then also kind of at each step along the way, having alternate options or alternatives to incarceration. And so the main components, you can see here, there's a map of LA County here. And it basically has the different sorts of structures and buildings and kind of like community-based interventions that they're proposing to make. First of all is youth development resources at the school with after-hours support. So they're basically proposing at every school or at most of the schools that the school remains open from 3 p.m. to 10 p.m. So that way the students have a place to go, a place to get work done, a place that's safe. And then in addition to kind of the school-based resources, also 24-hour youth community centers, residential support centers with housing options, and then few, but definitely treatment-oriented secure facilities for youth that we're not able to kind of capture in these other facilities. Okay, so I think that's pretty much everything. I'm glad that I'm somewhat on time. And so I guess at this point, we'll go ahead and take a pause. We can turn it over to Dr. Thompson and Dr. Dorman, see if they want to provide any additional comments, and then we'll kind of open it up for questions.
That was so wonderful, Laura. And there's so much to talk about. And we are incredibly lucky to have Dr. Thompson with us today. He is the director of the Forensic Psychiatry Division at Los Angeles County Department of Mental Health, and also associate clinical professor of psychiatry here at UCLA. So maybe while people are continuing to enter in questions, Dr. Thompson can give us some of his reflections.
Sure. Thanks so much, Liz. And Laura, thanks for that fantastic presentation. You did a great job of, I think, capturing some of the specifics and some of the kind of real people that are impacted by the juvenile justice system, and then gave a really nice landscape overview of things. I can kind of make some comments on the specific cases, if you like, and then could talk a little bit more about the diversion initiatives writ large. But I think the cases really illustrated some things that generalized to other cases. In your first case of the 15-year-old boy, one of the things that I was thinking about was how relatively minor things, trivial things, can lead to police contact. And the whole idea of even having school police there, and whether this situation could have been avoided if there weren't law enforcement present. That's been a big, I don't want to say argument point or bone of contention, but it's been a point of discussion in a lot of the youth justice work group activities, and the role of school police, and should they not be there. The other thing that the case captured, obviously, was high rates of anxiety disorders, particularly trauma-related disorders that you see in the juvenile justice system. And not every kid who has a trauma develops PTSD or even impairing symptoms, but probably 80 to 90% of our kids have traumatic experiences, maybe even a higher rate than that. And so that's really something that we are on the lookout for. And in the girls, but also the boys, there is the issue of sexual abuse, sexual trauma, and CSEC, so commercial sexual exploitation. And so we have separate kind of processes and programs to try to divert out girls who may be involved, have gotten involved in CSEC and been exploited in that way. I think you did the other issue of kind of confidentiality and the related role of letting patients in juvenile justice or even adult correctional systems know what your role is, because there is often a lot of confusion, and you can be seen as the agent of the probation department or the sheriff or some kind of agent of control. And it's also important to kind of make that clear with parents when you're talking to them as well. And there are a lot of misconceptions out there, like, just by way of example, I've been told on more than one occasion by parents that I get paid extra to prescribe medications to their kids. And I have to explain that that's not true. And that actually it's more work for me to prescribe medications. So I only do it if I think it's necessary. But carving out areas to be kind of, have some element of privacy with the youth, although that can be really challenging in correctional settings. And sometimes you have to make a few compromises for, to make sure that safety concerns are satisfied. But I think you can usually strike a pretty good balance with that. the other issue, I'm not sure if they're still doing this. This is not really a global issue, but the idea of sometimes when youth, or at least in juvenile hall, are hospitalized, they have to have a probation staff that accompanies them and stays on the unit. So I'm not sure if that's something that is kind of continuing to happen or not. The other thing with the first youth, the suicide risk and potentially violence risk, those are things that you have to kind of watch out for in youth that are involved in juvenile justice. Those things are just kind of higher baseline. The substance use disorders assessment and treatment, particularly because they're so integrally related to recidivism and deleterious mental health outcomes. So those are important. And then I think when you talked about one of the things we're kind of moving toward in the juvenile halls in particular is really looking at this as more of an inpatient model and beefing up the multidisciplinary treatment teams and really meeting on a several time weekly basis to try to address the needs of the youth from a multi-agency perspective. That's been going on for a while, but I think we're trying to really increase that. So, I mean, I think that kind of transposing that inpatient model to the correctional setting, I think is helpful. And then as far as your second case, the 17-year-old girl with autistic spectrum disorder, depression and ADHD, one of the things that kind of popped out to me was this idea of elopement and really not LA County's not having a lot in the way of secure non-correctional facilities. And so when you want to place youth, you have to conserve them, LPS conserve them, even if it might not be totally appropriate or totally kosher. And it's really done more to kind of check the box for the placement. So that's one of the things that the Youth Justice Work Group really took a look at, is how do we increase the access to secure non-correctional facilities so that judicial officers have an alternative to juvenile hall to place these youth. And one of the problems is that California is so restrictive with its regulations, and we as a society and the legislature and different departments may have to take a look at kind of rebalancing those liberty interests, least restrict. I mean, obviously we want least restrictive alternative, but if it's going to be juvenile hall or kind of a much nicer, secure non-correctional facility, that might be the lesser of two evils. There's a reason that a lot of private patients get shipped out of state to Utah or other states with less restrictive laws, but we don't really have that option in probation now. They ended out-of-state placements I want to say it was about 3 or 4 months ago because of some pretty bad incidents that went on in Michigan at one of the placements they were sending youth to. Yeah, and then the other thing that kind of struck me was this idea of attribution of behaviors, right? Like I think probation has changed significantly over the past 20 years, 30 years, and judicial officers to some extent too. And it's shifted from this is, quote, a bad kid to that there are multifactorial, this is a multifactorial picture, and there are a lot of things that are contributing to this, and mental health issues maybe and substance use may be significant contributors. So I think there's been more acceptance of that and kind of treating this as a medical issue or public health issue rather than like a criminal justice or punitive one. But there obviously are a lot of different philosophies, and every individual has their own kind of take on it. So to say that the approach is uniform would be overstating things. But I do think there's been a shift, and you can kind of see that on a larger level, just in the parallel processes that are going on with diversion. And on the adult side, I'll kind of segue into, I'll just say a couple words about that. You did a really nice job of covering the Youth Justice Work Group and all the work that was done in that and the timeline on that. The thing that wasn't on the timeline was that the U.S. Department of Justice was actually overseeing the juvenile halls and camps from 2004 to 2014. Started off in the halls for about, I want to say about 5 years, and then moved over to the camps in 2007, 2008. And so there was a lot more devotion of resources and improvement in care there. And then more recently, the California Department of Justice came in for investigation over the last year and a half or so. And there was a stipulated judgment that was signed about 2 weeks ago by the Board of Supervisors that has some provisions for primarily probation, but there were a few mental health items that we agreed to, mostly around increased staffing and kind of the enhanced multidisciplinary treatment team stuff. So, and then on the adult side, you alluded to this, but the Alternatives to Incarceration initiative that was started almost exactly at the same time as the OC spray phase out. So there was a Board of Supervisors motion in February 2019 that established the Alternatives to Incarceration work group. That group, using the sequential intercept model, met weekly, biweekly for almost a year, and then produced 100 and some page report, 125 or so recommendations and 26 foundational recommendations. And it was presented at the board at the last board meeting before COVID hit. And so the implementation was waylaid a bit for about, I'd say 4, 5, 6 months, but things are kind of back on track on the adult side. There was a Alternatives to Incarceration director that was hired in September. And so the process now is really trying to collate all the existing diversion resources and enhance areas where there may be room for enhancement, particularly around like misdemeanor and felony diversion on the front end, decarceration, keeping the jail population decreased. That was, we dropped from in the jail about 17,100 inmates to about 11,500 during the first 2 or 3 months of COVID, and then it ticked back up. So I think it's running around 15,000 right now. So there's a real interest in keeping those individuals in the community. The tension really is the services, and some of these individuals are pretty severely mentally ill. We just don't have the IMD beds and the higher acuity care, or even the just kind of more generic housing, ERS beds, board and cares. So especially when you have 60,000 homeless people in the county, and you're going to potentially add to that by letting individuals out of correctional settings, it's all movement in the right direction, but there are going to be some growing pains, I think, during that. So that's just kind of the general overview. I'm happy to talk about specific questions if anyone has them.
It looks like we do have one that, Dr. Thompson, I don't know if you can see on your Q&A screen, really asking about the deinstitutionalization and trans-institutionalization phenomenon and sort of how that plays into current ATI initiatives. Maybe you and Laura would like to take a step.
Do you want to take a crack at that first, Laura? Or?
I think that it's a really important point, and that I think one of the challenge, I think with anything that happens in the government, just keeping an eye on unfunded mandates and making sure if one thing is being closed, that whatever else is going to be needed, or a better way to meet that need, happens. And so I think it's a really important point that's being made in terms of budgetary constraints. And I do think these things are, at least as far as I'm aware, are on the radar of the county and the state. And that the second half of the report, which I didn't include here, was just like pages and pages of how much it's going to cost and where people think the money is going to come from. Of course, COVID changes, a lot of the ways things are funded in the state, and the way money is spent and the amount of money the state has are all going to be really impacted by COVID. So that's going to be a challenge. So Dr. Thompson, I don't know if you have more insight on kind of funding and budgetary constraints and.
Yeah. I think when you're trying to stand up all these different supports in the community, that's going to take some time. And there's going to be gaps, I think, in services for a period of time. And the funding is always kind of an issue. And what you see is some cost shifting from the state to the counties that's attempting to go on now and you see that with the DJJ, right? So the DJJ is now will be closing. It was going to be done fairly precipitously initially in 2021, and then there was more of a soft landing that was agreed to. But basically, that is transitioning these individuals back to the county. So the counties are going to be responsible for taking care of these youth, and there are basically block grants that are going to be provided to counties, but typically it's nowhere near enough money to kind of do right by these individuals. And this DJJ closure work group was kind of wrapped into the youth justice, the larger youth justice work group. But it's interesting because it's really a separate cohort of individuals that are going to require separate interventions. So these are, generally 18 to 25-year-old men who, DJJ can have custody of individuals if it's juvenile life up to age 25. So that's a very different kettle of fish than 13, 14, 15-year-olds in the juvenile hall. And, vocational training and voc rehab and other services that may not be as applicable to younger kids will be to these individuals. But there's a lot of we're going to have to see how devoted the county is to making this happen, because there is that's where the rubber meets the road. And you can certainly try to maximize efficiencies and cut the fat, but doing more with less only goes so far. So.
It looks like we have a couple more questions too for you both to tackle. Talking about LPS conservatorship, which is a challenging topic and something that you had to navigate, Laura.
Yeah. And so I think the kind of in there with the question is thinking about not ensuring that we're really trying to not misuse LPS conservatorship at the same time. And I think in the case with our patient, the feeling was, so to what LPS conservatorship is basically for at least a period of a year, saying that someone as a result of their mental illness is not able to provide for their basic needs. So food, clothing, shelter. And then, so long-term, over the course of a year, at least gravely disabled. And so then someone else is assigned to make decisions regarding those things and also mental health treatment. And so I think in our case, we thought about this very carefully. And the feeling was that the patient, due to the elopements and kind of her functioning, wasn't able to provide for these basic needs. And because of there were so much functional impairment and so many consequences, that the family wasn't able to either. I think that's another layer of complexity when it comes to LPS conservatives and youth, is thinking about kind of the youth not being able to provide for these needs, but also kind of like the family structure. And so our feeling was that she met criteria. And so that's a lot of, why we pursued it. And we also did think that it in her case made sense for her to be in a locked treatment facility. I think the things to think about is if it feels like there's a push towards LPS conserving a patient when they're not really meeting criteria, then there's a chance that they may be mismatched with the level of disposition that's being recommended kind of by the court. And so I think when you're thinking about LPS conservatorship, it's important to think about the criteria, to really note the importance of not over applying it. And that if it seems like you have to apply for conservatorship to have someone in a locked facility, but they're not meeting criteria for conservatorship, think about if they really need to be in a locked facility and if there's something else you can advocate for. I think historically there's been misuse of conservatorship in the case of CSEC. And as Dr. Thompson noted, I think and I know Dr. Bath works closely with that court, but that the county has developed kind of a process to support those patients that no longer requires or no longer is kind of asking for misuse of the conservatorship.
And I think one of the fixes may be legislative, that you have an alternative remedy and way to kind of have someone in a safe setting, potentially a secure setting, that we don't have to kind of muddy the waters with LPS as much. And I know there's been so many looks at LPS reform over the past 5 to 10 years, and it's a very fraught topic politically. But I imagine that will keep popping up over and over again, particularly when we see a lot of individuals homeless on the streets who have severe mental illness, and we're not able to kind of get them into conservatorship. And the county has actually started a pilot project where they're doing conservatorships of non-hospitalized individuals. The home team on the street will go out and do conservatorships of individuals who are homeless, and then try to get them into placement. There's also a process by which you can convert probate conservatorships into LPS conservatorships for non-hospitalized individuals in non-lock facilities. It is a kind of higher degree of difficulty, but I think we're going to see individuals taking advantage of that more over the next 3 to 5 years.
I think we'll take a few more minutes if people are willing to stick around for a few more minutes just to answer a couple more questions, or at least discuss a couple more questions. And then maybe we can end with, I'm sorry for the continued interloper, and then we can end with a little bit of discussion of how people can get involved in advocacy, which I can give a plug for at the end. But it looks like, staying on the inpatient question, Manal had a question, Laura, just about the consequences of involuntary detainment when you're keeping people beyond the 72-hour period. And, really, I think that's related to what you ended up having to determine in terms of LPS, but maybe you could comment on that a little bit before we move to Dr. McCracken's question.
Yeah, and so after the 72-hour hold, if someone continues to meet hold criteria, depending on which criteria, there's a variety of different holds that it can move along to. So 14-day holds, 30-day holds. The 72-hour hold itself is not reviewed by an officer of the court, but starting with the 14-day hold, that one is. And so I think then at that point, there becomes kind of court involvement, and patients are able to file, writs of habeas corpus, et cetera. In terms of repercussions, really the one that's like written on the hold and that you have to tell them about before they leave is there's a firearms probation. And so if someone's placed on a psychiatric hold, depending on which type of hold, how many lengths of holds, then they're not able to get a firearm within the state of California for a period of time. Again, just depending on how far the hold goes. Outside of that, it's really hard to say when it comes to the holds. I think if at some point someone's applying for something that requires that they disclose whether or not they've been involuntary held, they may have to disclose that. But otherwise, I don't know that there's a lot of like very, very strict, very clear, there's a database that everyone's able to see kind of sort of thing related to if someone's been on a hold in the past. So I don't think that outside of those things, I don't think there's a lot of like negative consequences to balance when someone really is meeting hold criteria.
And when we're thinking about how UCLA or really any academic medical center can collaborate with the county for diversion, there are a lot of thoughts that come to mind. Dr. Thompson, maybe you can lead us off with some of your thoughts.
Well, I guess one of the good things is that one of UCLA's former graduates is the director of the Department of Mental Health. So I think that helps foster that collaboration. And I know we have the Department of Mental Health and through it, our probation county partner have a training agreement with Tricia Lester's group. And so that's really been helpful, I think, doing some of the training initiatives. But I think that the academic partners have been involved through through a lot of these planning processes. Some reps from UCLA, USC, sometimes around data analysis and research, sometimes around provision of services. And so I think they already are involved, but certainly we will tap the academic institutions. Particularly, I have an affinity for UCLA since that was a place I trained for my adult and child, and bring them into some of these processes. But I think they have been involved.
And I would add 2 cents with when we're really thinking about these different intercepts, particularly for, in Laura's cases, these youth who have not been able to access care, and especially those youth who may have other developmental challenges that really require more specialty care. Increasing access within the UCLA system is really vital. And of course, that goes to accepting Medi-Cal patients. Of course, the vast majority of the folks that we're seeing in this system are Medi-Cal patients. And really thinking about how our outpatient system can transition to being able to serve the greater community. And I think also, I think about all the amazing work that Dr. Kaptaoka and others have done with schools, and that's going to continue to be so incredibly important. And my understanding is one of the next phases of discussion for the work group is really looking at educational partnerships, because that hasn't been fully fleshed out yet. And as Dr. Thompson and Laura mentioned, SROs in schools, we just had an initiative last summer with one of the LAUSD council members, Monica Garcia, pushing forward a plan which resulted in defunding school police by $25 million. Of course, the question is what fills that vacuum? So I think on the school front, we have so much expertise in UCLA folks, and then on that actual access to care, the outpatient front, which most of these kids are not getting, it would be an amazing thing to just to hear more about ways that UCLA could be involved in that. And I'll add, in terms of advocacy, I would highly recommend for folks who are interested and who want to learn more and stay connected with a lot of these initiatives. One of the easiest ways, and Laura and Dr. Thompson may have other ideas too, but it has worked really well for me to be involved in Justice LA and to get a lot of their texts and updates, and I can constantly stay abreast. Otherwise, I don't know how I ever would, of initiatives that are happening, and letters that you can send to your council members, and really just knowing what's happening on the ground and then deciding when you're ready to contribute your voice. And particularly as UCLA community members, that voice matters.
And I think CGP too, right? Through UCLA is another good source.
Absolutely.
They send out email blasts of a lot of the board motions and different initiatives that are going on, and things that are going on statewide too, and some of the other groups, anti-recidivism coalition. There are a lot of them that are involved with some of these projects as well. And just one other thing that kind of came to mind, Liz, when you were talking, is what I like to call like intercept -1 or intercept 0, and that's the prevention and early intervention aspect of things. And to the extent that academic medical centers can be part of that, and maybe even collaborate with organizations like First 5 LA, that's really where we're going to get the most bang for our buck from an investment standpoint. If we're going to think of it in cold hard numbers, obviously there's the personal and human cost. But by the time they get to us in the juvenile halls, it's so far down the road. So I think prenatal to 5 is a really important time period. So I think we need to kind of focus on that. And the other thing that Praveen Kambam really talks about and pushes, and he's another child and adolescent forensic psychiatrist who trained at UCLA and is in juvenile justice, is that we kind of arbitrarily separate these two initiatives, the youth justice work group and the alternatives to incarceration, when really this is a continuum of behavior. And really these are kids who there is a, something of a pattern to how things develop and how things progress. And so these are not individuals who just pop up at age 18 in one day in the adult criminal justice system. So to the extent that we're able to integrate these two initiatives and streams, if you will, I think that would help.
Yeah, definitely. And just to echo everything that's been said, I put in the chat some of the links to some of the websites of Justice LA and Reimagine LA and some of the different groups that are really engaged in a lot of the advocacy. And they're all like on Instagram and Twitter, and it's really easy to follow kind of what's going on. And when there's opportunities to, provide input to the Board of Supervisors or contact your individual supervisors or contact city council members, all of those are really easy to find through that. But then also keeping in mind, we've been mostly talking about like the structure, structural types of things in the system. Also keeping in mind when you interact with individual patients, while we're still waiting for these formalized pathways to really be there and something everyone has access to, we're all interacting with patients who have justice system involvement. I think if I look back just over the last 10 years, last 2 years or so, I've been keeping a running list of like the justice involved patients who I've had a chance to work with. And there's like 8 to 10 patients on that list. And so I think that if we're thinking about, it doesn't sound like a ton, but I think many of the trainees within the program will have the opportunity to interact with the justice involved youth and know that there's ways you can think about that youth, and then ways you can really work when it comes to their intervention on a system level that can make a big difference.
I think we've hit our time limit, but there's so much more to talk about too. And thank you all for everyone who submitted questions. Thank you so much. And Laura and Dr. Thompson, so fabulous to hear all your ideas and thoughts about these very important issues.
Thanks for having us. We appreciate the chance to get the word out. And if people have I know no one has a lot of spare time, but if you can read those reports online, the Youth Justice Work Group report and the DJJ closure report and the alternatives to incarceration, just Google those things and add LA County and I'll take you right to it.
Yeah, they're like very readable, very beautiful figures. I would definitely encourage it. All right.
Thank you, Laura.
Yeah, thanks to everyone. I really appreciate your time.
Thanks, everybody. Stay safe. Get your vaccine.
Bye.
Bye-bye.